Hello, and welcome to the CAP Today webinar for Thursday, April 11th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentation. Today's webinar is entitled Liquid Biopsy and Concurrent Testing Strategies for Patients with Metastatic Non-Small Cell Lung Cancer, or NSCLC. This critical session, I want you to know, is sponsored by AstraZeneca in partnership with OncoLens. We wish to acknowledge both companies and thank them for their support in helping us bring to you this important program. Today's speaker, who's joining us once again on a CAP Today webinar, is Dr. Zin Htway of the HCA Los Robles Hospital and Medical Center in California, and I'll say more about Dr. Htway in due course. But before we begin, as always, I'll say a few things about housekeeping that can help you appreciate today's seminar even more. So first, we suggest that you refresh your browser. We do have live help available throughout today's presentation. You'll see the number below the slide deck, 858-345-5916. We have live operators standing by to help you with slides or audio. You may also type your questions in the Q&A box, which you'll see under my picture on the lower right-hand side of your screen. And again, that's primarily there for your own comments and questions as we go through the webinar. And we'll wait for the presentation to be over, and then we'll have a question and answer session. So stick around for that. In about a week, we're going to be able to post the full audio and full slides of today's webinar, and those will be posted at captodayonline.com for your pleasure and review. You will receive some follow-up email from us and perhaps our sponsors, so I want you to know that. And finally, let me remind you that CAP Today does not endorse any products or services that may be named today. And any comments or remarks that I may make are purely personal, obviously not to be taken as policy of the CAP Today or the College of American Pathologists. And now I mentioned that AstraZeneca was sponsoring this in partnership with OncoLens, and I wanted to take a few minutes with a guest speaker, great friend Jeremy Stapp, who's going to spend a few seconds introducing OncoLens. We have a slide for him, so we'll show that, and I'll ask Jeremy to speak to you now. Jeremy Stapp.
Great. Thank you, Bob. Hello, everyone. Thank you, AstraZeneca, and to CAP Today for this opportunity. Many of you may be familiar with OncoLens due to our tumor boards and peer-to-peer discussion platform. However, I did just want to take a moment to introduce ourselves to those who may not be familiar with us. We are a data-driven oncology treatment planning company that brings together both structured and unstructured data from EHRs, labs, radiology systems, all for the multidisciplinary care team. We have a proprietary AI engine that we're able to provide solutions for several needs of cancer centers across the U.S. and internationally, some of which I just wanted to highlight: identifying difficult-to-find patients who match the clinical trials offered by our site. We are able to identify patients who are matched for CAR-T therapy, as well as quality improvement projects often focused on improving biomarker testing rates through custom reports of patients who need biomarker tests such as germline or somatic testing. Happy to answer any other questions, and thank you again to Bob, CAP Today, and AstraZeneca for the opportunity.
Jeremy, thank you very much. And Jeremy will be with us throughout today and will be available also for questions or comments. And now with that, I'm going to turn to our main program today. Once again, it's liquid biopsy testing strategies for patients with metastatic non-small cell lung cancer, a case-based program in precision medicine from AstraZeneca. It's my job now to give you the brief program disclaimer. I'll read that for you. This program is an interactive, case-based approach to educate healthcare providers on the role of precision medicine in non-small cell lung cancer, with a focus on liquid biopsy testing to help optimize the diagnostic journey for patients with metastatic non-small cell lung cancer. This program uses case scenarios that are representative of real-world situations and that provide examples of integration of liquid biopsy testing to stimulate dialogue and encourage a multidisciplinary approach to testing. In an effort to focus the discussion around biomarker testing, we kindly ask that you refrain from any conversations or questions regarding treatment decisions based on the scenarios presented. And now it's my great pleasure to introduce our speaker, Dr. Zin Htway, studied at UCLA. He got his doctorate degree at Walford College, and I'm going to ask him now to read the program objectives for today and then begin his presentation. Dr. Htway.
Oh, thank you so much, Bob, and thank you to CAP today, AstraZeneca, and Oncolens for inviting me. Today's program objectives, we're going to first look at and discuss the impact of biomarker testing for the appropriate care of patients with non-small cell lung cancer. Secondly, we're going to review the potential benefits of integrating liquid biopsy with standard of care tissue testing on turnaround time and identification of patients with actionable biomarkers in metastatic non-small cell lung cancer. And thirdly, we're going to explore patient case scenarios, just one case scenario, that demonstrate potential successes and implementation considerations for liquid biopsy integration in the metastatic non-small cell lung cancer. So first we'll take a look at the role of precision medicine in non-small cell lung cancer. Now, as we're all well aware, lung cancer is the leading cause of cancer death in the United States, right? It's one of the most commonly diagnosed cancers, and it results in the leading cause of death compared to prostate, colorectal, and breast cancers. If we look at our graph here, you'll see that the incidence of lung cancer is about 12.2%. However, death rate is about 28, almost 21%. When we look historically, the deaths from the most common kind of lung cancers, the non-small cell, from each year from 2006 to 2013 fell by about 3.2%. And then after 2013 to 2016, fell even more so by 6.3%. The accelerating decline of non-small cell lung cancer mortality that began corresponds with the time when clinical guidelines began recommending molecular testing for the EGFR mutations, ALK rearrangements, right? Those common biomarkers that we've seen. And so we like to attribute this fall in the death rate due to the actionable biomarker identification and targeted treatments. Right. So non-small cell lung cancer classification is evolved over the years to span numerous subsets of actionable oncogenic-driven metastatic diseases. We see a lot of familiar names on the left-hand side, right? And so over the past decade, there's been a growing list of specific predictive biomarkers for actionable genetic alterations, and we expect that that list will continue to grow into the future, which is really quite important when ordering broad molecular testing. So NCCN clinical practice guidelines in oncology, right? Our NCCN guidelines recommends biomarker testing for eligible patients with metastatic non-small cell. So we look at first on the left-hand side, whom to test, those with the metastatic, non-squamous, and then what to test. And then, we've got some familiar names here, EGFR, ALK, KRAS, ROS1, BRAF, right? And the testing should be conducted as part of broad molecular profiling. We keep using that term because utilizing the broad molecular profiling, you're actually consuming less tissue. And we know that having tissue to work up is really the heart of all of this. There are emerging biomarkers to identify novel therapies for patients with metastatic non-small cell lung cancer. Example is at the high-level MET amplifications. Now the question comes to how to test. Now traditionally we've done a tissue specimen, right, our diagnostic biopsy. But over the past few years, we're seeing growing implementation and utilization of liquid biopsy or plasma specimen. Those situations where it becomes very useful is if tissue is insufficient or unavailable, the consideration of complementary tissue and liquid testing to maximize biomarker detection, and we'll see more about that later on in the presentation. And then also consider concurrent tissue liquid biomarker testing, as it may aid in biomarker evaluation and reduce time to results, which we'll see a little bit later as well. And the comprehensive genomic profiling can provide more complete information on all types of genetic alterations with potential therapeutic relevance. Using the broad approach, you can test all actionable biomarkers at one time. This may reduce the need to repeat invasive biopsy procedures, for which we never really want to have to repeat a biopsy. We may reduce time to treatment. Currently, right now, as we'll see, time to treatment is really quite extended. If we can get that shorter, it helps out the patient in a lot of ways. May also increase incidental identification of low prevalence biomarkers. And lastly here, can identify biomarkers that currently have no FDA approval therapies to match eligible patients, but can match into clinical trials as recommended for all patients with metastatic non-small cell lung cancer per the NCCN guidelines. So there's a lot of benefit to the broad molecular profiling. When we look at treatment driven by diagnostic testing, we found there's an overall increase in survival for those with the advanced non-small cell lung cancer. For those patients that had received diagnostic testing, the median survival was 18 months. To those without diagnostic testing, where median survival was about 6 months. So a 12-month increase there in the median survival. So it's really quite huge. And if we look at the sample size, right, it's almost 6,000 for those. So biomarker testing is also guideline recommended for certain patients with resectable non-small cell lung cancer. When we take a look at the prevalence of the EGFR mutations across stages 1 to 3 of non-small cell adenocarcinoma, we can see that it does, 20%, between 18 and 20% for stages 1, 2, and 3. So there's no reason not to actually test regardless of these stages. And then disease recurrence or death following surgery with or without adjuvant treatment, including chemotherapy, remains high across disease stages in resectable non-small cell. The 5-year recurrence rate or death in the resectable, when looking at stage 1B, you're looking at about 45%. At stage 2, there's an increase to 62%, and then at stage 3B, we're up to about 76%, where the median follow-up is about 5.2 years. So once again, we're looking at recurrence or death. So when we consider whom to test, right? We're considering resectable stages 1B through 3A, 3B. What to test? EGFR mutations, ALK variants, and of course the PD-L1 status. And then how to test with tissue specimens, is preoperative biopsy or the operating room surgical resection samples. Now, even though liquid biopsy testing is not clinically validated for genomic profiling in the resectable non-small cell setting, there's still a lot of benefit to it. Retrospective study utilized the NGS, which is the next-gen sequencing, to evaluate presence of driver mutations, right, in 197 patients, genes in patients with treatment-naive non-small cell lung cancer. Positive concordance between matched plasma and tissue, right, increased with disease stages, which of course, we would expect. Stage 1, we're looking at 12%. Stage 2, we're looking at a little over 58%. And stage 3 is around 55, 56%. But once you get to stage 4, you're looking at almost 74%. So tissue testing and liquid biopsy can be complementary tools to help with biomarker evaluation. So integrating liquid biopsy to support precision medicine in metastatic non-small cell lung cancer. So There are multiple procedural methods are available for acquiring tissue. We have the bronchoscopy, transthoracic, thoracentesis, surgical, either a thoracoscopy or thoracotomy, and then we have liquid biopsy. Now, when we look at the aspects which are clinically validated, we can see that tissue for both resectable and metastatic is there, but for plasma, resectable is not yet. The CAP, NSCLC, and AMP guidelines state that biomarker testing can be performed on tissue specimens obtained by any procedure. However, liquid biopsy is not currently validated in the resectable non-small cell lung cancer setting. And many of us are familiar with the potential challenges associated with tissue acquisition for non-small cell. We have patient factors, comorbidity, poor performance status, bleeding complications. You also have patient refusal. We have tumor factors. The tumor lesion is not readily accessible. When we look at the tissue biopsy failure, feasibility rates, or patient refusal, tissue biopsy can fail. You could have insufficient tumor cells in the collection, even though you can get a diagnosis of malignancy, there may not be enough tumor DNA, which can result in the inadequate tissue quality, quantity, and also quality. Tissue biopsy not feasible, right? The tumor is inaccessible. There's the associated risks, such as, of course, bleeding, and of course, pneumothorax, and then there are approximately about 2% of patients that refuse to go under biopsy. There was a real-world study that highlights challenges in biomarker testing. In the Mind-Lung Consortium, patients receiving biomarker testing results, when we look at the test types for ALK across all histologies, there was about 70%. Same for EGFR, a little bit less for ROS1. BRAF is down to 55%, and then PD-L1 much higher, because PD-L1, of course, is done by immunohistochemistry. But for all 5 biomarker tests, we're looking at about 46% for all histologies. And then when it comes to next-gen sequencing, there's quite a bit drop. It goes down to about 37%. So when we look at the median time from testing order to results, we're looking somewhere between 10 to 15 days. And then when we look at the median time from diagnosis to first-line therapy, we're looking at 5 weeks. So as a patient, that's a really long, that's a long wait. A lot of anxiety, and also, because we know that the aggressive nature of, non-small cell lung cancer, the earlier treatment, the better the patient will be. So the recommendations are really to have upfront comprehensive testing for all guideline recommended biomarkers, right? They may help ensure appropriate and timely treatment decision making. More than 20% of patients did not receive biomarker testing or test results prior to initiation of first-line treatment due to unavailability or unavailable test results or tests not ordered. And this is one of those aspects where we definitely want to see a change where we're getting more testing, so that way you have the results before beginning the first-line therapy. In the metastatic non-small cell lung cancer, liquid biopsy presents a useful tool or useful diagnostic tool for identifying tumor-specific genomic alterations. So when we have our patient, right, with the metastatic non-small cell lung cancer, you can do essentially a venipuncture, because the blood collected may contain the circulating or cell-free DNA released from healthy tissue and also from tumor tissue. The plasma is prepared, and then they can do a circulating tumor DNA detection, which can detect most of the same that we're looking at: deletions, insertions, point mutations, amplifications, translocations, and of course chromosomal aberrations. So we'll see this slide a couple of times here, but guidelines recommend integration of liquid biopsy. We have a patient, metastatic non-small cell, unknown biomarker at diagnosis. You've got tissue samples are available for tumor genotyping. That's on our left-hand side. You've got adequate tissue for genotyping, then the tumor tissue is genotyped, and then you want to take into consideration about doing plasma testing, right? Just in case, or comprehensive or sequential approach plasma testing, just in case, right? there's a failure along the way. If tumor tissue is scant or say uncertain, right, uncertain adequacy for genotyping, then you want to take a complementary approach where you're doing the plasma testing concurrently. Now, of course, if the tumor sample is unavailable for tumor genotyping, right, then of course you just want to go with the plasma first approach and get it worked up from there. You may want to consider rebiopsy for tumor tissue genotyping in the case of absence of targetable drivers in plasma. So if the plasma sample comes up as negative, then you might want to revisit going after tissue again. So, liquid biopsy or plasma, right, and tissue-based testing are used to identify actionable mutations, right, in the eligible patients at diagnosis of metastatic non-small cell lung cancer. So, of course, when you've got patients with the metastatic non-small cell initial diagnosis, you want to go tissue and also liquid because the actual biomarker status may help to make those informed clinical decisions, right? Getting back to so many patients that receive first-line therapy without a actionable biomarker diagnosis or without the molecular results. So, and of course, NCCN guidelines, recommend liquid biopsy testing for eligible patients within the metastatic non-small cell lung cancer setting. Now, both tissue testing and liquid biopsy have advantages and considerations, right? With tissue, it's invasive. Liquid, it's more non-invasive. You've got your pre-analytical factors. Tissue may be insufficient because there's inadequate tissue acquisition or perhaps even processing, right? Once the tissue biopsy is taken, if it's not promptly put into, formalin and if it's left out, then you can see some, bad things can essentially happen to the molecular markers. When it comes with the liquid biopsy, plasma testing, you have to make sure that, well, it's hard to make sure, but that there's sufficient quantity of DNA within the blood that's actually drawn. There's also a possibility of improper processing because the sample collected also needs to be properly processed. Analytical factors, for tissue, you got widespread availability of highly sensitive assays, which is great. And for plasma, right, the analytical factors can overcome tumor heterogeneity. However, multiple factors can influence tumor DNA shedding, tumor size, location, and then, of course, the vascularity. When we look at turnaround time for tissue, we're somewhere between 5 to 20 days. And then when we look at liquid biopsy, this is a huge advantage, is 3 to 10 days for the next-gen sequencing, including send-outs. And then test completion rates, for tissue, you've got inadequate specimen acquisition contributes to a wide range of completed testing rates with interpretable results. And then with liquid biopsy, tests consistently show high completion rates. So, and once again, in terms of the clinical validation, right, for tissue resectable and metastatic, and then just metastatic for liquid biopsy. So when we look at liquid biopsy, it's concordant with tissue-based. In one study, the overall concordance between tissue next-gen sequencing and liquid next-gen sequencing was over 81%. And then in a second study, concordance between positive liquid next-gen sequencing and tissue next-gen sequencing for the 8 therapeutic actionable biomarkers was over 96%. So concordance is high in both studies. And of course, when we consider specificity and sensitivity, right? According to NCCN guidelines in eligible patients, a positive driver mutation result alone from plasma testing is sufficient to select first-line treatment. And then when we look at the sensitivity, according to the NCCN guidelines, a negative result requires confirmation with tissue-based testing, and this is for the plasma testing. So if you've got a positive result, you can act on it, but if you've got a negative result on plasma, then you're going to want to see if you can acquire some tissue. And then when we look at appropriate treatment choices for patients with metastatic non-small cell lung cancer, right? when we look at tissue or liquid-based, we can see progression-free survival, right? Looking at those with the EGFR mutation, we look at circulating tumor DNA, which is in the burgundy line, compared to tissue. We can see that progression-free survival, it's very, very similar, right, with both of those. So, but there was no significant difference essentially in the progression-free survival after EGFR TKI treatment, regardless if it was plasma or tissue-based. And then when we consider turnaround time is maybe shorter for liquid biopsy. When we look at the DDR-PCR for tissue, the median turnaround time was about 12 days, and then for the plasma DDR-PCR, it was about 3 days. When we look at tissue, next-gen sequencing, the median turnaround time was about 20 days, and then for the plasma next-gen sequencing, it was about 9 days. So the median turnaround time was about 9 days. So you can definitely see, it's clear that the turnaround time is vastly improved with liquid or with plasma compared to tissue. And then when we take a look at the impact of integrating liquid biopsy when tissue quantity is not sufficient for testing, or when tissue tests fail in the metastatic setting, right? So if tissue is quantity insufficient or under genotyped, right, we can see that with liquid biopsy, it was actually able to pick up 19% actionable biomarkers in those patients. And when we combined both liquid and tissue, right, or if we just look at tissue alone, it was able to identify 383 patients, but then combining, right, liquid and tissue, it increased to 635 patients. So integrating liquid biopsy testing increased actual biomarker identification by 65%, which is huge. Now, the University of Pennsylvania study assessed if concurrent liquid biopsy and tissue testing improved detection of actionable mutations. So they had 3 cohorts. There was one cohort that was liquid NGS, only patient and physician preference. They had liquid only, no tissue, or NGS possible. And then they had concurrent tissue NGS. And so it's concurrent liquid and tissue next-gen sequencing. So then when we look at the outcomes here, for those patients who had concurrent, right, in this University of Pennsylvania study, when we look at mutations identified by the tissue test, you've got a little over 20%. Mutations identified by liquid or by plasma was about almost 29%. And then when you look at that group, which had both liquid or plasma and tissue, we're almost at 36%. So, concurrent testing may identify more patients with actual mutations than either tissue or liquid biopsy testing alone. So once again, there's steady evidence that concurrent testing between using both plasma and tissue is basically going to give you your patients better results. So, and then of course, plasma genotyping at the time of diagnosis decreased time to treatment, right? Because we already know that there's a decrease in the turnaround time, and then we start looking at time to treatment in themselves. So we had, there were 2 cohorts. You had one cohort 1 that had both plasma and our tissue, and then the other cohort just underwent just tissue NGS. When we looking at the results of this for cohort 1 that had, first availability of next-gen sequencing results on first oncology appointment, in cohort 1, it was about 85%, right? Compared to cohort 2, it was only about 9%. Treatment initiated on first oncology appointment, right? 74% compared to 46% for cohort 2. And then when we considered the median time to treatment for cohort 1, it was about 10 days, and we're looking at cohort 2 about 9 days. And those are all patients with oncogenic driver mutation was identified. So from these 3 graphs, you can see the advantages of combining both plasma and tissue, the concurrent. So keys, as I mentioned earlier, you really have to control the pre-analytical blood specimens, all of that to make sure that, to ensure that you're going to get accurate results. First thing that we look at is really time to first processing step, initial blood draw, and then separation of the plasma. And recommendation is less than 60 minutes. The method of acquisition, the tube type, the draw order, the volume, methods of stabilization through tube inversion, method of processing, centrifugation, speed, time, right? Centrifugation temperature, storage conditions, and then of course, data documentation. Failures anywhere along the way here are not going to benefit the patient or the patient's results. And so just like with tissue that we always have to process appropriately and document appropriately, the same also goes for plasma. So there are some, potential strategies for integrating liquid biopsy in the clinical practice for patients with metastatic non-small cell lung cancer. Clinical scenario number one, tissue is unavailable for genotyping, right? You're attempting to obtain additional tumor tissue, adds delays. You can go ahead and order liquid biopsy, right? Followed by biopsy for tissue testing if the actual genomic alterations are not detected in plasma. So if the plasma comes back negative, then try and go for more tissue. Scenario two, tissue is available, but it's uncertain adequacy for genotyping, potential for a quantity not sufficient, which is essentially the three worst words that you can see on a report. There you want to go with concurrent liquid biopsy and tissue testing, or tissue testing following the liquid biopsy, right? Especially if the tumor burden is low, the circulating tumor DNA shed may be lower. The other option is to do liquid biopsy testing followed by tissue testing, again, if tumor burden is high. In clinical scenario three, tissue is available and appears adequate for genotyping, right? But then we've got that need for urgent start to therapy. So of course you can send out, tumor tissue genotyping, or you could do concurrent liquid biopsy and tissue testing. So here's an example of a process map for biomarker testing to incorporate liquid biopsy in the metastatic non-small cell lung cancer setting. This process map was developed by Dr. Farah Kahil and Dr. Michelle Schiller. We have tissue collection, where it's collected by the proceduralist, our interventional radiologist, or interventional pulmonologist, or thoracic surgeon. We get that histological diagnosis and staging. That's done through our anatomic pathologist, who makes the histologic diagnosis. And then there's the ordering of testing, right? You could have on-demand, non-reflexive testing, or on a case-by-case basis. It could be standardized non-reflective testing per group or institutional workflow. And there's also the reflexive pathologist-initiated testing, which is automatic testing based on preset criteria. Every institution has its own way of ordering. And when it comes to processing tumor sample, adequacy is, they'll do molecular testing for PD-L1 through IHC. If the adequacy is uncertain, then you want to go for liquid biopsy and look at, concurrent cell-free DNA, right? Tumor tissue genotyping. If it's not adequate, then you want to go with liquid biopsy for the cell-free DNA. If that doesn't work out well, then you get a negative result, then you want to try the tissue rebiopsy. But if the liquid biopsy does give you an actual marker, then you can compare that with the tumor tissue genotyping, and then you start doing reporting. And the lab will send reports to the ordering healthcare provider, and the ordering healthcare provider disseminates the results to the multidisciplinary team. So, taking a look at our clinical scenario, we're just going to do a single case today. This is our case 3, but this is the only one that we're going to cover today, where we have concurrent liquid and tissue testing when rapid turnaround time is critical. So on day 0, we have initial presentation of our patient. The patient presents in the ED with an episode of hemoptysis, and this is not unusual. They order a CT chest, and we see a large left upper lobe mass on the CT image. Same day, the ED physician consults with a hospital pulmonologist. The pulmonologist orders a PET CT, recommends bronchoscopy. The next day, the pulmonologist performs the bronchoscopy overview. Bronchoscopy revealed a friable endobronchial mass, right? Specimen was obtained, placed in fixative, sent to pathology for lab processing into a tissue block. Of course, in pathology, it's the next day you're going to get results. You're going to get slides out. The histopathologic diagnosis, the pathologist establishes diagnosis, enters it into the EMR. Diagnosis is adenocarcinoma, and this is on day 2. Day 4, workup is continued, right? PET CT shows large left upper lobe mass, no discrete adenopathy, multiple lung and osseous metastases. On day 5, patient is transferred to the thoracic cancer center. Patient's anxious, wants to start treatment as soon as possible, connects with the nurse navigator at the cancer center. Due to the urgency of the case, nurse navigator consults medical oncologist to review records, patient records, history, presentation, path report, chest CT, PET CT findings. Same day on day 5, the med-onc, right, reviews all of that information based on diagnosis, available staging information, and highly symptomatic patient status, as well as unpredictability of insufficient tissue will be available. The med-onc places an order for concurrent liquid and tissue tests. Same day, day 5, the nurse navigator schedules the patient for consultation, calls pathology laboratory for tissue specimen. Hospital pathologist is actually whom the nurse navigator speaks with. And so in this hypothetical case, scenarios, right, we're looking at concurrent testing, and we saw this slide earlier. You want to do both tissue and liquid, right, because concurrently might be appropriate for some patients, and it is in this scenario, right? Our patient's highly symptomatic, you have hemoptysis, patient's anxious to start treatment, and then the uncertainty of sufficient tissue availability. When you have a large tumor, there's a lot of necrosis that goes along with it, so there's where your uncertainty comes from. So, and we saw this slide earlier, guideline recommendations where, you're looking at, tissues adequate, tissues uncertain, or tissues unavailable. And just to, once again, to repeat, we saw the slide earlier, liquid, plasma tissue-based testing are always useful, are used to identify actionable markers, and which we're hoping for here in our patient. So getting back to our patient journey, on day 7, the nurse navigator, patient comes to the thoracic cancer center, blood sample collection. The nurse navigator coordinates sending the blood specimen to the commercial laboratory for liquid biopsy testing. And then on day 9, the pathologist receives the tissue block, performs specimen assessment, and then sends the tissue to the reference laboratory. And both the plasma as well as the tissue were sent for next-gen sequencing, a 324 gene panel for plasma, and then 123 gene panel with PD-L1 for tissue. Now, of course, retrieval of tissue samples may impact institutions meeting the CAP, ISLAC, and AMP recommended guidelines, right? There's pre-analytical factors, there's delays, in getting that formula fixed paraffin embedded specimen, shipment to the reference laboratory. The guidelines is like less than 1 day. Pre-testing period should be less than 3 days, and then the analytical period is probably going to be greater than 10 days. For getting back to our patient journey, testing results on day 11, the molecular pathologist has the PD-L1 test results, enters those into the EMR, right? And it shows expression. The med-onc on day 11 also sees these results, but the molecular tests are still pending. And, when it comes to PD-L1 expression, right, you can get it essentially, because it's by IHC, you can get the PD-L1 results on day 2. However, it's still recommended to wait until day 4, until all the molecular tests come back, which in this example is about 14 days, about 2 weeks later. So you want to wait until all of the results are back before initiating treatment. In looking at the PD-L1 expression and also with actual biomarkers, we see that there's overlap for the EGFR mutation positive. There's about an 80% overlap with showing also PD-L1 expression. So that's why it's important to wait for all of the driver mutation results to come back. When we look at on the right-hand side, in terms of comparing driver mutation with PD-L1 expression, for ROS1 it's 100%, MET 75, RET 75, and then BRAF at 70, ALK is 63, right? KRAS is about 66, and then HER2 is about 53. So once again, it's important to wait for all the results to come back before initiating treatment. So and once again, you're right, there's no evidence to support the use of IO therapy as first-line treatment for patients with metastatic non-small cell lung cancer whose tumors harbor certain EGFR or ALK alterations. Getting back to our patient, on day 15, they have the liquid biopsy test report, shows the EGFR exon 19 deletion, positive. That's the nurse navigator, same day, arranges patient consultation with MED-ONC for the following day, which is going to be on day 16. The MED-ONC meets with the patient, discusses first-line treatment with the patient itself, and then 2 weeks later, on day 30, the tissue test report comes back and confirms there's presence of the EGFR exon 19 deletion positive. So now we've got all of our answers and we can begin treatment. So you can see that by doing concurrent testing, we're able to limit to 30 days versus, say, sequential testing, which would have increased beyond the 30 days. So by doing the concurrent testing, you've got all your answers by the time that when you get your last set of answers, which are going to be on the tissue test report. So once again, we saw this slide earlier, just to take into consideration, advantages, and then also the other considerations of tissue-based and also plasma. And then once again, just to remind everybody about the turnaround time, that like liquid plasma biopsy turnaround times are significantly shorter than tissue. And then regarding the integration of both liquid and tissue in terms of identifying actionable biomarkers, right? Concurrently, you can see in the purple bar significantly higher than liquid alone or tissue alone. And then for at least one actionable biomarker, once again, we've got something very similar. And then, of course, when we take a look at, turnaround time for the University of Pennsylvania prospective study for cohort 1, time to initial treatment, right, was only 10 days, where cohort 2 was 19 days. Remember, cohort 2 was tissue only. And then in a prospective Nile study, when they looked at that, you had for blood, it was 18 days versus 31 days time to initial treatment. So the case scenario summary, on day 5, the MED-ONC requests concurrent liquid and tissue NGS testing. PD-L1 comes back on day 11. Liquid biopsy results come back on day 15. Day 16, the MED-ONC meets with the patient, and then on day 30, the tissue test results are available and align with the plasma results. So our key takeaways is that when rapid turnaround time is critical, concurrent liquid and tissue testing practices may be particularly beneficial in certain case scenarios, and current data indicate that this approach may increase the detection of therapeutically actionable biomarkers. Despite differences in turnaround times for all biomarker test results, it's important to know all laboratory results prior to selecting therapy, if clinically feasible. And then positive results for therapeutically actionable biomarkers on liquid biopsy tests alone are sufficient to help inform appropriate treatment selections. And at this point, I'm going to turn it back over to Bob. Thank you, Bob.
Thank you, Dr. Htway, for a very comprehensive look at liquid biopsy and the testing considerations in non-small cell lung cancer. I know that you, along with me, will be anxious to review this great presentation. And as I mentioned before, it will be posted in about a week at captodayonline.com. And now, if I can give Dr. Htway a chance to catch his breath, we'll begin with some questions and comments. Let me first address a question on the actual blood collection, if you may. Dr. Htway, which blood collection tube do you use for sample collection, and how quickly is the sample processed after the initial draw?
So regarding the tubes themselves, that's going to be laboratory specific. The labs that are running the plasma have their own standard operating protocols, and it's advisable to just follow those, because if I give any description, it's going to be different than, it could be different than some labs that are out there. So
understood, indeed. And the same questioner had a question. What kind of measures can you take to protect patient confidentiality when you're doing comprehensive sequence data analysis? This is a generic problem of patient confidentiality, but would you like to make a comment about that, Dr. Htway?
So in terms of patient confidentiality, like any testing to any reference laboratory, right, in the pathology lab in itself, we do maintain all of our HIPAA standards. And if necessary, you need to essentially de-identify patients by using perhaps, if not their medical record number, perhaps their account number for that particular visit themselves. But in terms of, you basically aren't going to be sharing that information out, unless it's with the multidisciplinary team for, patient care and patient treatment. Does that answer the question, Bob?
I think it does quite well. Thank you. Now, when we talk about concurrent tissue testing and liquid biopsy, we clearly get ourselves very quickly into a payment and reimbursement discussion, which I don't particularly want to get down in those weeds. But I want to ask you a more general question, Dr. Htway, about difficulties and dealing with insurance companies to cover either the concurrent tissue testing or, indeed, liquid biopsy itself.
Yeah, it is quite of a challenge, because it does go from payer to payer, and there are variations in terms of inpatients versus outpatients. So especially when you're looking at Medicare, DRGs, it does vary quite a bit, and also from institution to institution, regarding for-profit versus nonprofit. It's just really something where the multidisciplinary team needs to get together with, I would say, hospital administration, lab administration, also with essentially admitting to make sure that whatever they can do, but it's going to be definitely institution by institution based.
Absolutely. I mean, I think the general advice would be to start early and include all the people affected within your institution to come up with a plan to approach insurers and payers, correct?
Yeah, exactly. Start early. That's definitely, start before you collect the specimen, so at least you have an idea of how to essentially properly bill for it. So, and collect for it. So.
Exactly. Now, we have quite a few questions here, and I'd be interested in your response to those. Obviously, many people look to liquid biopsy as being a new element in terms of our ability to assess response to therapy. Do you have some experience with that, and what is the promise of that?
So I know my experience in that is somewhat limited. There are some institutions, some reference laboratories that are essentially taking liquid biopsy from a patient, analyzing it, and then the patients are receiving treatment, and then periodically the patient can get essentially another analysis of plasma to see if there's any changes in the mutations. But these are done, the patients themselves are essentially tracked by a very specific reference laboratory. So you can actually see the progression or any changes in the circulating tumor DNA. but that's about really my extent to it. I'm not sure who's or which laboratories are actually doing that. I know there was a lot of talk about that last year, but in terms of patients, I haven't had any direct contact with any of those patients or any of the oncologists who are doing that.
Very good. Just as another note of homework, it would be very smart to know exactly what your given reference laboratory is doing with these kinds of assays, and they can fill you in.
Right. So, exactly.
So the other question that always arises with liquid biopsy, and we have several again, could you ever envision a liquid biopsy test for non-small cell cancer biomarkers being used for possible screening of patients in the future?
Yes, actually, there's a number of clinical trials going on right now where they're collecting essentially plasma for analysis on patients that are essentially cancer naive and also treatment naive. So these individuals do not have a diagnosis of cancer, but plasma is being collected prior to biopsy, and then when the diagnosis comes out, then there's a correlation done between the two. At our institution here, we're actually in discussions currently on becoming a site for one of these clinical trials. The reason for us being selected is because we do so many invasive procedures on patients' biopsies throughout interventional radiology. We have a very robust program there, as well as interventional pulmonology. So that's why we're actually looking into becoming a site for one of these studies.
Understood. There are several questions. Perhaps you could say a bit more. What time to treatment differences have you seen or would you imagine might occur when the tissue or liquid biopsy is sent out to another lab versus having it all performed in-house, so to speak?
So for those laboratories who are fortunate enough to be able to run in-house, you really save days because, for us, we have to send out for our next-gen sequencing. We just don't have the capabilities of doing it. But you could send the block and then find out that, the block a couple of days later, or that the block is going to be insufficient. And some of the labs that we send to will give us that information sooner than later. So then you have to send perhaps a second block. The difficulty there is that the challenge is that you've already lost 3 or 4 days, or maybe even like a week. But if, with the concurrent testing, you can definitely get those results back sooner. So, you still need, when tissue is available, you still want to send it, right? And you still want to match the results up at the end. But, yeah, it's just, there's definitely some, you have to look at it to see how you can really optimize turnaround, to optimize your turnaround time for results.
Very good. Thank you. Now, Dr. Htway, I'm sure that you and many, many of our audience participants have the experience of patients who are very, very anxious to initiate immunotherapy in the case of their early diagnosis of non-small cell lung cancer or other cancers. And you sometimes have surgeons or even oncologists who are also anxious to get on that. Could you discuss that? Because I'd like you to underline again, if you might, the importance of getting all the relevant biomarkers in the case assembled before treatment decisions are made.
Right. Yeah. No, it's a great question, Bob, because, it's a very romantic idea that a patient's immune system can fight their cancer. However, it's been shown that using targeted therapy for the actual biomarkers has a better result, better outcome. It's also been shown in certain studies that starting with the IO agent, right, the immuno-oncology agent, actually has an adverse effect against the effectiveness of targeting the actual biomarker. So, for the students, the patients that we have, they don't, when we're first meeting them, they don't have a diagnosis of cancer. They have a tumor that we're going to be working on, they're very anxious for the results, and they'll let us know that, I have an appointment on, next week, or I have an appointment in 10 days. So we also want to be certain to give them an idea of how long our turnaround time is going to be, right, for the initial diagnosis, and then that if necessary, we're going to be sending out to a reference laboratory, and to let them know that the reference laboratory, whatever we send there, it's because of treatment. It's not because of the diagnosis. And then we have to wait until all of those results come back. But I think that for patients, informing them of the potential timeline of how long it's really going to take, it kind of does reduce a bit of the anxiety, because they know now what to expect.
Yes.
But yeah, in terms of the PD-1 and the IO agents, I do hear that a lot, often from patients that want to get started, because like I said, it's a very romantic idea to have your own immune system fight your cancer for you.
Yes, indeed. Thank you. That's really a wonderful answer. I'm always reminded in this immediate context of the importance of waiting to ID and perform AST on infectious diseases, and so that we don't jump right ahead to inappropriate antibiotic therapy, which tends to really mask and delay eventual resolution of infection. I think there's some cancers in which this is there's a great parallel. Do you agree?
Oh, I certainly agree. And for a lot of our patients who have, a lung tumor, and we're approaching it because, it's FDG added, it looks and smells like cancer, but then it turns out to be an Aspergillus infection, right?
Okay.
It does happen. But once again, you've got to work up, we can tell you it's an infectious organism, but until the samples come out of the microbiology laboratory with results, you really can't treat. So once again, you're waiting again. So it's essentially worth the wait, or it's important to wait to get the right treatment.
Yes, thanks very much. I'm going to send you one more question, and I think we'll make that the last question for today, as we're approaching the top of the hour. And this is one really where you can help the audience understand how does liquid biopsy, compared to something we used to talk about more frequently and still do, the capture of circulating tumor cells. Talk about compare and contrast liquid biopsy and the capture of circulating tumor cells, per se.
So with the liquid biopsy, you're looking for the cell-free DNA, where the DNA in itself is essentially free-floating due to like the rapid growth and the angiogenesis of tumors. And then also tumors, they grow, some of them grow so quickly, so fast, that they basically cut their own blood supply off, and then they go through a process of cell death, releasing their DNA into the system. For circulating tumor cells, it's not cell-free DNA. These are actual tumor cells that are floating around in the vascular system. And so this is where, the reference laboratory that the lab is going to be utilizing, or if they're doing it in-house, it's important because the methodologies are different. And so that's the basic difference right there. In terms of turnaround time, part of the reason why turnaround time with liquid biopsy is so much faster than tissue is because tissue, the overnight the processing through formalin and the wax and all that, you have to essentially undo the damage that fixation has done. And so there's a bit of a delay right there. And also getting the tissue out of the block, making sure that you have enough. So there's a lot more workup with tissue versus something that's already soluble, so to speak.
Very good. That's a wonderful answer and very, very enlightening. I hope everyone had a chance to digest that, because that's as well put as any I've ever heard in explaining the difference between the two.
Great. Thank you.
Thank you. And with that, I'll leave that last word with you, but I'll proceed here, addressing now the audience. We really do want to hear from you. AstraZeneca is, of course, anxious that they know what you thought about today's presentation. You've got a QR code there that you can scan with your camera. We tested this on our screens, and it does indeed work. You can also, and here you should look below the slide, there's a URL email AstraZeneca.com web app, and a very long, unpronounceable suffix, but still, it's one where you can type into your browser and have the survey come up for you, and I recommend that you certainly do that. Finally, I want to end with the statement that's important to make. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. And with that, our program today is concluded, and I will begin to wrap up as your moderator. I'd like to thank, of course, Dr. Zin Htway for a magnificent presentation today. It's going to be worth restudying, and I thought the clarification was outstanding, as was the substance of each and every slide. So I want to thank Dr. Htway. I also want to thank OncoLens and Jeremy Stapp. You can reach out to them to talk about how OncoLens can complement the testing process, identifying patients, ensuring test results get delivered to the entire care team. They've got an important platform that you should inform yourself with, and I want to thank them for their partnership. And finally, I want to thank AstraZeneca for their sponsorship of today's program in partnership, again, with OncoLens. We've worked with them a lot, and they're wonderful partners. I highly recommend that. And to close, I want to thank all of you, the participants today. I know how busy you are. Your schedules are very full, so we're always gratified when you take time to join us for a CAP Today webinar, and we're always anxious to know what you think, and we look forward to seeing you again in the future. So once again, thanks to Dr. Htway, thanks to Jeremy Stapp, thanks to OncoLens, and thanks for AstraZeneca. And with that, I will bring today's webinar to a close.